Kotidis, που είναι consultant pediatric cardiologist και electrophysiologist στο πανεπιστήμιο, στα πανεπιστημιακές κλινικές του Λέστερ. Έχετε το λόγο, κύριε Kotidis.
I will make my speech in English. Thank you, Prof. Thimiadis, for the invitation. I will try my best to cover all the three components, especially as most of you are adult cardiologists, and we all know that kids are not little adults. So there are some differences between adult and pediatric hypertrophic cardiomyopathy. The lower penetrance makes this less common, and however, these patients have high risk of sudden death compared to adult patients, with up to 2% risk of sudden death per year. We also see secondary hypertrophic cardiomyopathies, that some of them do not survive to reach adult life, and they have higher mortality. These are due to metabolic, syndromic, and endocrine disorders. The phenotypic manifestations in hypertrophic cardiomyopathy in children are more subtle, and we have to have higher clinical suspicion when we investigate these patients. And this makes our work even more difficult, as the lower numbers, more subtle presentation results in lack of data and evidence, and this leads to limited ability to discriminate between high and low risk patients. This is one of recent meta-analysis from the group from Great Ormond Street Hospital. They combined studies reaching almost 3,500 patients, and they identified major and minor risk factors. When we assess risk factors, we have to pay attention on the hazard ratios, because each of these risk factors does not have the same weight. So previous adverse cardiac event has a hazard ratio of 5. The next more significant non-sustained ventricular tachycardia has almost 50% less relative risk ratio of 2. So they identified all these 5 components: unexplained syncope, extreme left ventricular hypertrophy, and left atrial dilatation that is likely to be an additional significant risk factor. We have to understand all the minor risk factors. They have a hazard ratio close to 1, and this is family history of sudden death, age, symptoms, ECG changes, and abnormal blood pressure response to exercise, and LVOT obstruction. Late gadolinium enhancement is nowhere there, because it takes time to build a scar in pediatric population. So, apart from the European group, North American group has devised also a prediction model. Mainly, the main difference between the two is the age of diagnosis. So, and this is non-linear in their prediction model. The group from America has both interventricular septal thickness and left ventricular posterior wall thickness in their model, and this is combined into one risk factor in the European risk stratification model. So both models have almost the same prediction ability, with C statistic around 0.7, and this, however, even with this fair prediction ability, we need to implant 10 ICDs to save the life of one patient, and this is not ideal. So when we assess the risk, when we speak with the families, we have to balance the risks and make a cost-benefit ratio assessment for the individual patient that we have in front of us. And this in pediatrics is challenging because there are limited data, imperfect risk prediction models, and the disease is also rare, but with life-changing events. And on the other hand, we know that in pediatric population, implantation of device is high risk for complications, much higher than adult life-threatening risk of life-threatening complications, and has a big impact on the mental health of our patients. So we have to keep in mind that the diagnosis is not binary, it's a spectrum of severity, and our aim is to grade this severity, and the risk assessment is even more complicated. As we saw, there are multiple risk factors. So this is the risk prediction when you have three parameters, X, Y, and Z. When you have 4, 5, 6, our brain cannot comprehend this risk, and we need finally to devise the risk scores. However, the decision for an ICD implantation is binary. You put the ICD or you don't put the ICD. So for this reason, it is very important to have shared decision-making with the families, to inform them, to educate them, to spend time with them, and this is very challenging. And we have to explain in a lay language, depending on who do we have in front of us. Is he a professor in cardiology, or is somebody a refugee that cannot even speak the language? And in pediatrics, this shared decision-making is even more challenging because we have the young person, family members, grandparents, godfathers, everybody, and the professional. So this interaction is often complicated. This is the recommendations for ICD in pediatrics. Class 1 is aborted death or cardiac arrest, and the guidelines say that any children with hypertrophic cardiomyopathy with one or more primary risk factors can consider for ICD implantation, but we rarely do this because, and we have to discuss with the patients. It's different to consider risk factor age or a risk factor left atrial dilatation than a massive hypertrophy. And even the third one, having a late gadolinium enhancement, is not very common in pediatrics, and we even know that the ability of MRI to detect scar in pediatric patients is more limited than in adults. So, as we mentioned before, we have many challenges in ICD implantation in children: higher complication rates, risk of lead fracture during rapid growth, venous obstruction with multiple leads. Hopefully, we can transfer these patients to the adult cardiologist, and this is becoming not our problems. Damage to the device due to increased physical activity, and smaller children have limited anatomic options for ICD generator placement. This is a nationwide study from Denmark where we can see that appropriate therapy is around 60% in 10 years, but the complication rate reaches also around 50% of patients in 10 years follow-up. So as pediatric cardiologists, we are quite creative, and you can see here, and we have to be because of the patient size. Here you can see a system with subcutaneous shock leads, posterior and anterior, and the generator boxes around the abdomen, and we have tunneled the pacing leads subcutaneously, and we put it transvenously. So, and this is how the lateral X-ray looks. And sometimes we have to go be even more creative, to go epicardially with additional leads. other configuration here, and even in very small patients where we are concerned for device erosion, we have to put the device in the pleural spaces, and this can be done surgically. So exercise, moving to exercise, we all know the beneficial effects of exercise, but in children this is even more important because their development, their brain growth, their social skills depend also on exercise. So restricting a child from exercise is not a simple decision. But we all have the concerns that for exercise-induced arrhythmias, and our role historically has been to restrict patients from exercise and tell them what they cannot do. Nowadays, our role is to tell what can they do safely and invest and navigate this journey with the families and in a stepwise and safe manner. So in studies with pediatric patients with hypertrophic cardiomyopathy, it is proved that the exercise improves diastolic function, improves exercise capacity and quality of life, and vigorous exercise in genotype positive patients, but phenotype negative has no significant adverse events. However, we have to keep in mind that mean age of death in the general population is 18 years, and 65% of these deaths come from athletes below 17 years of age. So this makes our work even more challenging. So when we assess these patients, we have to do a personalized assessment, personalized medicine, assess for symptoms, risk stratify them, check with an exercise test for LVOT obstruction, and their blood pressure response to exercise, and resting or exercise-induced arrhythmias. And finally, these are the more recent recommendations for sports cardiology. We can pay attention on the limited, on the low class of evidence. And in general, any asymptomatic patient with no evidence of hypertrophy can do even competitive sports, even if it is gene positive. And subsequently, we have to do a personalized assessment and assess the risk score and decide to exclude patients from competitive sports. But even we should pay attention on this part. Participation in low or moderate intensity recreational exercise, if desired, may be considered even in patients with increased risk. And this comes after intensive investigation of this patient. I will move forward because I'm running out of time. So when we prescribe exercise, it is the same as any medication. We have to assess what dose. This is the time that we spend doing exercise, frequency, how many times per day or per week here we should do exercise, what kind of exercise, and this guidance is very helpful for the decision aid. For interventional treatments, all these are in research settings for children, and we can do alcohol septal ablation with high chances of AV block in our population, and even radiofrequency or cryotherapy to ablate the hypertrophic section of the heart. And this was one of my consultants that recently died. He's a pioneer. He was a pioneer in Birmingham. He did ablation, radiofrequency ablation in children, 32 patients with resulting reduction of gradient from 78 to 36. One death occurred not due to procedural complications, but because of paradoxical increase of LVOT obstruction. One pacemaker that is not an issue for these patients because they should have an ICD, and 6 patients required further procedures. So in conclusion, kids are not little adults, and there are certain specific considerations for them, and especially communication with families and in decision making. We have to, and we need actually international collaboration for more data collection, evidence-based practice, and development of pediatric-specific equipment. I'm using the adult equipment. There are no, all this research is company-led, not government-led, and so our work is challenging, adjusting this equipment for any size of patients. Thank you for the invitation. This is our team.
Thank you, Mr. Kotidis. The commentators, please.
Στα ελληνικά θα προτιμήσω, μια και βρισκόμαστε στην Ελλάδα. Λοιπόν, σας ευχαριστούμε πάρα πολύ για την ομιλία αυτή και για την άποψη του ηλεκτροφυσιολόγου. Εγώ να μείνω λίγο στο ότι πλέον στη βιβλιογραφία εμφανίζονται risk και για τα παιδιά, σταθμισμένα πλέον. Οπότε υπάρχει ένα καινούργιο εργαλείο σε αυτή την κατεύθυνση. Δεύτερον, την απενεχοποίηση ή τέλος πάντων την έναρξη απενεχοποίησης της άσκησης, για την οποία υπάρχουν δεδομένα κυρίως στους ενήλικες. Και ένα τρίτο που θα ήθελα να ρωτήσω, όσον αφορά τον προσδιορισμό, το risk score, κάθε πότε συστήνεται για τα παιδιά. Και ένα δεύτερο, μας είπατε πολύ αναλυτικά τα δεδομένα που υπάρχουν όσον αφορά τα ηλεκτροφυσιολογικά δεδομένα και τις παρεμβάσεις στις μηχανικές, επεμβατικές κτλ. Έχει δοκιμαστεί φαρμακευτική ουσία στα παιδιά, όπως υπάρχει αντίστοιχη επιλογή στους ενήλικες? Αυτά.
Ναι, δίνουμε beta blockers, είναι στάνταρ η θεραπεία. Εννοείται για αριθμίες ή για την θεραπεία της καρδιακής αναπάρκειας?
Της υπερτροφικής καρδιοπάθειας, αν υπάρχουν πρώιμα δεδομένα ή κάτι τέτοιο, αν έχει αρχίσει να δοκιμάζονται.
Στο Great Street δοκιμάζουν τους νέους παράγοντες για specific gene diagnosis με promising results.
Ναι. Okay. Και για τον προσδιορισμό του risk score στα παιδιά, κάθε πότε?
Ναι, αυτό είναι σε κάθε assessment που θα κάνεις.
Εξατομικευμένα.
Ναι. Μερικούς τους βλέπουμε ανά 6 μήνες, μερικούς ανά 1 μήνα. Άμα είναι phenotype negative, έχουμε annual assessments. Άμα έχουν ήδη LVOT obstruction, θα τους δούμε και πιο συχνά.
Ευχαριστώ πολύ.
Θερμά συγχαρητήρια, κύριε Κωτίδη. Ήσασταν εξαιρετικός. Σε σύντομο χρονικό διάστημα μας περιγράψατε πάρα πολύ ωραία το θέμα. Τα άλλα μισά συγχαρητήρια όμως ανήκουν και στον πρόεδρο, ο οποίος έκανε μια άριστη επιλογή.
Σας ευχαριστώ.
Λοιπόν, το ερώτημα που θα ήθελα να σας υποβάλω σχετίζεται με αυτές τις ηλικίες που εγώ προσωπικά δεν έχω εμπειρία, δεδομένου ότι δουλεύω σε ένα νοσοκομείο ενηλίκων αποκλειστικά. Έχει να κάνει όσον αφορά την χρήση των απεινιδωτών. Πόσο εύκολα μπορεί να ληφθεί μια τέτοια απόφαση εμφύτευσης μιας τέτοιας συσκευής?
Ναι. Άμα ένα παιδί παρουσιάζει VT ή το έχουν αναζωογονήσει μετά από cardiac arrest, δεν υπάρχει ερώτηση. Ακόμα και έχουμε, παραδείγματος χάρη, παιδιά με long QT Brugada syndrome, τα οποία έχουμε βάλει απεινιδωτή στους 2-3 μήνες. Αυτά είναι τα epicardial που βλέπετε στο pleural space. Αλλά από εκεί και πέρα το threshold για το οποίο θα κάνουμε εμείς decision for ICD implantation είναι πολύ υψηλότερο από ό,τι στους ενήλικες. Οι ενήλικες μπορείς να το βάλεις έτσι. Και επιπλέον δύσκολο είναι το concept του consent. Okay. Εκεί ο γονέας αποφασίζει για κάτι που θα συνοδεύει το παιδί για όλη τη ζωή, αλλά με πολλές όμως επιπλοκές. Δηλαδή ενδοκαρδίτιδες, erosions. Υπάρχουν παιδιά τα οποία μπορούν να είναι στο νοσοκομείο 3-4 μήνες μετά από ένα complication. Αυτό είναι μεγάλο το impact για την οικογένεια. Οπότε το threshold είναι μεγαλύτερο επειδή κιόλας δεν βλέπουμε υπερτροφίες τόσο πολλές όσο βλέπετε εσείς στους ενήλικες.
Και άλλο ένα σχόλιο, μου επιτρέπετε, όσον αφορά τα ανταγωνιστικά και μη ανταγωνιστικά αθλήματα. Ένα τέτοιο παιδάκι, σε τι άθλημα θα μπορούσε, κατά τη γνώμη σας, να συμμετάσχει? Σαφώς στα μη ανταγωνιστικά, αλλά υπάρχει κάποιος διαχωρισμός περαιτέρω?
Ναι. Για μένα, όταν συμβουλεύω αυτές τις οικογένειες, είναι ότι καταρχήν, άμα δεν είναι high risk το παιδί, δεν θα πρέπει να το κάνουμε, να το περιορίζουμε από τις συνηθισμένες δραστηριότητες στο σχολείο, έτσι ώστε το παιδί αυτό να αισθάνεται απομονωμένο, να είναι θύμα bullying και ούτω καθεξής. Από εκεί και πέρα, άμα μπορείς να κάνεις test exercise, αν κοπώσεις σε ένα παιδί, κάνεις το test exercise και από εκεί μπορείς να πάρεις πολλές χρήσιμες πληροφορίες και βλέπεις και την οικογένεια. Υπάρχουν οικογένειες οι οποίες θέλουν το παιδί τους να γίνει αθλητής. Υπάρχουν άλλα παιδιά τα οποία δεν τους ενδιαφέρει ο αθλητισμός. Οπότε αυτό πρέπει να είναι ένα share decision με την οικογένεια. Δεν μπορούμε να το παίζουμε θεοί ότι αυτό πρέπει να κάνεις. Εντάξει.
Συγχαρητήρια.
Σας ευχαριστούμε.
Ευχαριστώ πολύ.
Εδώ κλείνουμε το session γιατί έχει περάσει πάρα πολύ ο χρόνος. Όσες ερωτήσεις στα διάλειμματα με τον κύριο Κωτίδη. Ευχαριστώ.